Welcome to our online nephrology lectures. In this playlist, we are discussing different chapters of the hemodialysis book, Nephrotube Synopsis of Conventional Hemodialysis. This is lecture number 9. In the previous lecture, we started discussing chapter 8, Complications during hemodialysis. The previous lecture was part 1. We discussed in it intradialytic hypotension and the intradialytic hypertension. In this lecture and also in the coming lecture, we will continue the discussion of complications of hemodialysis. In this lecture, we will discuss the muscle cramps, hemolysis, air embolism, disequilibrium syndrome, and seizures. In the description of this video in YouTube, below the video, we will find some important links. The first link is a link to this same lecture, but in Arabic language, for those who like to watch the lecture in Arabic. We'll find also a link to the playlist of video lectures about this book. You will find the link for the English playlist and Arabic playlist. We'll find link to download this book for free. We'll find link to download the PDF of this lecture for free if you like to use it. You will find the link for my website Nephrotube, nephrotube.com, where you will find more lectures about nephrology than hemodialysis lectures. And finally, you will find a link to Nephrotube social media accounts, the WhatsApp group, the Telegram channel, the Facebook group. You can join us to be always updated by the activities of Nephrotube. And finally, it's better to subscribe to our channel and to make the notifications on from our channel, so you will be notified once we upload new lectures. Let's start our discussion and explanation by muscle cramps. What about timing of muscle cramps in relation to the hemodialysis session? It is well known that most of the cramps are commonly observed during or near the end of the dialysis session. This may be due to the effect of hypovolemia or hypoosmolarity that I will show in next slides. So what are the pathogenesis explaining a muscle cramps occurrence during a hemodialysis session? The first theory is related to hypotension and hypovolemia due to excessive ultrafiltration or rapid ultrafiltration. And the hypotension and the hypovolemia will cause muscle ischemia and precipitate muscle cramps. Also, there is evidence that hypoosmolarity that can occur during hemodialysis, whatever the cause, due to shift of urea from the intravascular compartment to the dialyzer, as we mentioned in the previous lecture in the explanation of intradialytic hypotension, that the diffusion of urea may cause hypoosmolarity. Also, if you are using low dialysate sodium, this will cause shift of sodium from the blood to the dialysate, causing also hypoosmolarity. Whatever the cause of hypoosmolarity, there is evidence that this hypoosmolarity will cause muscle cramps independently of hypotension or volume depletion. Many patients have muscle cramps without hypotension and hypovolemia, and this could be explained by hypoosmolarity. Especially that these cases with the suggestion that the hypoosmolarity is the cause of the muscle cramps respond in a positive manner to hypertonic solutions that I will mention later in the management of muscle cramps. The next may be electrolyte disturbance. Electrolyte disturbance may be the cause of muscle cramps. For example, as I mentioned, if you are using low sodium dialysate, this may precipitate cramps, maybe due to the hypoosmolarity in the blood that is caused by this low sodium dialysate. Also, hypocalcemia will precipitate cramps. Hypomagnesemia will precipitate cramps and is related to resistant cramps to treatment. And finally, if there is pre-dialysis hypokalemia, this may precipitate cramps, especially if you are using low dialysate potassium less than 2 millimole per liter. And finally, peripheral vascular disease may precipitate muscle cramps, and you have to exclude peripheral vascular disease in your patients on hemodialysis with resistant muscle cramps, as we will mention later in the prevention. Okay, what is the management of muscle cramps? First, you have to give intravenous solutions. If muscle cramps is associated with, if muscle cramps are associated with hypotension, treatment with normal saline can be used, isotonic saline. But actually, it doesn't always resolve the cramps, as we mentioned that hypoosmolarity has rule in some cases. That's why, as it doesn't always resolve the cramps, hypertonic solutions, especially hypertonic glucose, are the treatment of choice. Because hypertonic solutions will correct the hypoosmolarity. Which hypertonic solution to use? The preferred one is hypertonic glucose, although we don't like it for fear of fistula injury, but it is the treatment of choice, and you have to use it in non-diabetic patients to resolve the cramps. Hypertonic saline can be used, but actually, as we mentioned before, it can induce thirst and intradialytic weight gain. Mannitol in general is not recommended in dialysis patients, as it can accumulate in dialysis patients and shouldn't be used. So hypertonic glucose is the preferred one. The second line for treatment of muscle cramps is physical therapy. The first one is forced stretching. The patient or the nurse or the attending physician must help the patient to stretch the cramped muscle. Second line, massage. You can try it. It is not effective in all cases, but can you try it? And finally, local heat application on the affected muscles may resolve the muscle cramp. You can supply your patient with nasal oxygen because it showed that it may have a benefit in the treatment of muscle cramps. And finally, but it is not commonly used actually in practice, there is evidence that nifedipine orally 10 mg sometimes reserves cramps, but actually it must be used in hemodynamically stable patients, but this is not a common practice, by the way. So this is the management of muscle cramps. What about prevention? How to prevent the occurrence of muscle cramps in our patients, especially in those with recurrent muscle cramps on hemodialysis? First of all, we mentioned that hypotension and hypovolemia may be a precipitating factor for the occurrence of muscle cramps, so prevent hypotensive episodes during the hemodialysis session. And we mentioned that in details in our previous lecture, lecture 8, where we discussed the preventive measures of intradialytic hypotension. The second point that can be used to prevent the occurrence of muscle cramps is physical therapy. First of them is a stretching exercise. Multiple stretches. Stretching as a football player or whatever the sport, the patient has to stretch his muscle frequently, and actually this is beneficial to prevent cramps associated with dialysis and also nocturnal cramps that are common in patients on hemodialysis. The second physical therapy, but it is not commonly used according to my knowledge, is compression devices. It is a device that the patient has to wear in his leg, and it makes vibration and compression on the legs muscles, on the leg muscles, and this may improve the vascularity of the muscles and prevent muscle spasm. The third line to prevent muscle cramps is dialysate-related measures. You can raise the dialysate sodium to prevent hypoosmolarity, but again, using a high dialysate sodium may increase interdialytic weight gain due to thirst, blood pressure, and it will cause rapid ultrafiltration, as we mentioned in previous lecture. Also, dialysate magnesium shouldn't be low. must be high. Using dialysate sodium, low dialysate magnesium may cause muscle cramps. The fourth point for the prevention of muscle cramps, especially in patients with frequent muscle cramps, you have to check pre-dialysis serum level of different electrolytes. So calcium, potassium, magnesium, and correct these. If there is any abnormal low level, you have correct it. But take care while you are giving a patient on hemodialysis a magnesium supplement, because it may be injurious in these patients. So you have to watch your dose and watch your patient for any side effects. Can I use any medications for prevention of muscle cramps? The answer is yes. What are the medications that can be used? The first one is carnitine. You can give intravenous carnitine 1 gram after each hemodialysis session. Some literature showed that higher doses of carnitine are used, but the most commonly used dose is 1 gram carnitine after each hemodialysis session. There is evidence that oxazepam can be used in the form of 5 to 10 milligram 2 hours before dialysis. There is also evidence about vitamin E can be given in the dose of 400 international units at bedtime. You can increase the dose up to 800 international units per day. Doses of vitamin E exceeding 1000 international units per day is not safe in patients on hemodialysis. Clean sulfate, although it is very effective in the prevention of muscle cramps, but it has a lot of side effects in patients on hemodialysis, and it is totally contraindicated. The last line, especially in patients who have resistant recurrent muscle cramps, is to rule out any peripheral vascular disease. You can refer your patient to the vascular surgeon to check the vascularity of lower limbs. Now we finished our discussion about muscle cramps. Now we have to go to discuss hemolysis. Hemolysis is a rare condition in hemodialysis, but it may be fatal in some occasions. What can cause hemolysis during a hemodialysis session? First of all, faulty roller pump. There is a problem in the blood pump where it compresses the tubing set very strong and very hard, causing destruction of red blood cells and hemolysis. The second cause of hemolysis during a hemodialysis session, if there is any obstruction or narrowing in the bloodline, the needle from the fistula and catheter. For example, there is here narrowing in the bloodline, which can cause hemolysis, and you can see here the blood is very dark, secondary to hemolysis, and I will talk later about the color of blood in the dialysate circuit, in the extracorporeal circuit, secondary to hemolysis. Also, if you are using a very high blood flow rate, while you are using a small needle size during hemodialysis, small needle size with high blood flow rate will cause hemolysis of red blood cells. And we will talk later in the lectures of vascular access about the different sizes of AV fistula or AV graft needles and the accepted blood flow rate for each size of each fistula, of each needle. The third cause that may cause hemolysis is problems with dialysate solution. Overheated dialysate can cause hemolysis. Hypotonic dialysate, whatever the cause, due to insufficient concentrate to water ratio, there is a lot of water than concentrate in the dialysate, will cause hypotonic dialysate, and this will cause hemolysis. And finally, if there is contamination of dialysate due to chloramine, chlorine, copper, or nitrates, due to inappropriate water treatment unit function, in this case, this will be a disaster. Yeah. By the way, if there is a faulty roller pump, this will affect one patient. The patient who is dialyzed on the machine with the faulty roller pump. In case of obstruction, narrowing in bloodline, needle, or catheter, this also will affect one patient, the patient who had this problem. Overheated dialysate will affect also one patient. Hypotonic dialysate will also affect one patient because the dialysate temperature and tonicity depends on the hemodialysis machine itself. But if there is contamination due to chloramine, chlorine, copper, or nitrate, this means that there is a problem in the water treatment unit itself, and this will affect all the patients in the hemodialysis unit at the same time, and this will be a disaster. That's why it is important to maintain the quality of water treatment unit as we mentioned before. What are the manifestations of hemolysis on hemodialysis? It depends according to the onset of hemolysis. If the hemolysis is acute and massive hemolysis, there will be back pain, chest tightness, and shortness of breath of the patient. The color of the blood will be port wine-like color. This is the normal color of the blood. It is a very dark red color of the blood, which is called the port wine appearance. And if you centrifuged this blood, you will find the color changed to pink. So in the hemodialysis circuit, it will be port wine-like, which means that it is dark blood. And in the tube, after centrifugation, you will find a pink color discoloration of the plasma. The third, for sure, secondary to hemolysis, you will find a severe drop in hemoglobin and hematocrit, and for sure, there will be hyperkalemia that can cause muscle weakness, ECG changes as hyperacute T wave, and for sure may be cardiac arrest and death. These are the manifestations for acute massive hemolysis, but if the hemolysis is chronic mild subclinical due to non-fatal cause, as kink in the arterial bloodline, or faulty roller pump if it is not that severe, the diagnosis of subclinical hemolysis actually will be challenging, and it will not be diagnosed except by investigations. For example, you will find the patient has a recurrent muscle weakness after the hemodialysis session. By investigations, you can find that in comparison to the pre-dialysis hemoglobin level and potassium level, you will find that after the dialysis session there is increase in the potassium and decrease in hemoglobin. This may raise the suspicion of chronic mild subclinical hemolysis. What about the management? If you have a patient with hemolysis or group of patients, first of all, you have to stop the dialysis and hospitalize the patient. Important point that when you stop dialysis, the bloodline should be clamped, and the blood in the blood circuit shouldn't be returned back to the patient, as the blood circuit contains hemolyzed blood that for sure has a very high potassium content, and it shouldn't be reinfused back to the patients to avoid severe hyperkalemia. And for sure you have to hospitalize the patient for observation and for continuation of the management, and also hospitalization is important as there is a possibility of delayed hemolysis of injured red blood cells after the dialysis termination. Then you have to order lab tests as potassium, complete blood count, reticulocytic count, and lactate dehydrogenase, and for sure you have order ECG. You have to treat hyperkalemia with the known anti-hyperkalemic measures, and for sure you have to transfuse blood to the patient, but take care that blood transfusion itself may cause hyperkalemia. So before blood transfusion, be sure that you corrected the hyperkalemia and you are controlling it. And finally, you have to search for the cause of hemolysis, especially checking of the dialysate, or especially checking the water treatment unit to be sure that its quality is good and that it form purified clear water that is used in dialysate, and it must be within the accepted range of the chloramine, chlorine, copper, or nitrate in the dialysis water. After that, we will discuss air embolism. Air embolism actually it is a very rare condition, but it is a life-threatening complication. What are the sites of air entry during a hemodialysis session to the patient? First of all, this is the extracorporeal circuit that we mentioned before. The air can enter the circuit through the arterial needle of the fistula, or if there is accidentally open end of the central venous catheter of the patient. Also, there may be entry of air from the pre-pump arterial tubing segment, for example, through the saline infusion line, and also heparin line may be a site of air entry. What are the manifestations of air embolism? First, you will find foam in the bloodline, not only the venous line. In all the bloodline you can find foam, as in the picture. And regarding the symptoms of the patient, the symptoms depend on the patient position. The symptoms are position dependent. In seated patients, the air embolism, the air travels to the cerebral venous system and obstructs it without passing through the heart, and this for sure will cause convulsions, coma, and maybe death. In recumbent position, there are three possibilities. The first, for sure, the air will enter the heart, and this will cause churning sound during auscultation. Churning sound as like wave sound, for example. And it may obstruct the air embolism, may obstruct the right ventricular outflow, causing acute right ventricular failure. Furthermore, if the air embolism passes the right ventricle, it will pass to the lung and obstruct pulmonary capillaries. And for sure, this will cause dyspnea, cough, chest tightness, pulmonary edema, and respiratory failure. Further on, if air passes through the pulmonary capillaries, it will reach the left ventricle, and from the air ventricle, air embolization can pass to arteries of the brain, which can cause acute neurologic symptoms, or to the heart vessels, coronaries, and these can cause cardiac dysfunction. Okay, what is the management of air embolism? First of all, for sure, you have to stop blood pump, clamp the venous bloodline, and don't return the blood back to the patient, because the bloodline contains a lot of air. Then you have to quickly position the patient in a left-sided recumbent position with the head and chest bent downward, and then you have to administer 100% oxygen. And finally, it may be necessary by the aid of cardiothoracic surgeon to evacuate the air from ventricle or atrium by cardiac catheterization or maybe percutaneous needle insertion. The next complication that we have to discuss, and it is common than hemolysis and air embolism, which is disequilibrium syndrome. Disequilibrium syndrome actually is a manifestation or is an abnormal condition that affects the central nervous the central nervous system, with central nervous system manifestations that can occur during hemodialysis. Before going through the pathogenesis of disequilibrium syndrome, what are the manifestations of disequilibrium syndrome? There are two forms of disequilibrium syndrome, the mild form and severe form. In the mild forms and in the early time of the severe form, there may be nausea, vomiting, restlessness, and headache. More in the severe form, you can find seizures, coma. So the cases start in severe forms by nausea, vomiting, restlessness, headache, and then it will be followed by more severe manifestations. But in milder form, it will be only nausea, vomiting, and headache. The next question, is disequilibrium common in acute hemodialysis or chronic dialysis? Chronic dialysis, here I mean patients who are stable on hemodialysis since long time. They are dialyzing 3 times per week. In acute hemodialysis, I mean patients with acute hemodialysis due to, for example, acute kidney injury, or even chronic patients who are dialyzing for the first or second time. Disequilibrium syndrome occurs more commonly in acutely uremic patients, in the acute cases, in the first dialysis sessions, especially in those patients who are dialyzed aggressively with high blood pump, high dialysate flow, large size filter, and I will mention why this is more common in patients who are dialyzed aggressively when I am talking about pathogenesis in next slides. In patients who are undergoing chronic dialysis, disequilibrium can occur, but in milder forms. And it is important point to mention that disequilibrium syndrome, as I will mention later, it will be a diagnosis of exclusion in both cases. For example, if a patient you have a patient on chronic hemodialysis and he's stable on chronic hemodialysis, but at the end of hemodialysis session, the patient has nausea, vomiting, and so on, and you have excluded all other causes of hypotension, all causes of vomiting. So the possibility now may be mild disequilibrium syndrome, and we will talk about this later in the diagnosis. Regarding pathogenesis of disequilibrium syndrome, we have 3 theories explaining the disequilibrium syndrome: the rapid lowering of plasma osmolarity, paradoxical CSF acidosis, and idiogenic osmoles effect. Let's start by the first one, rapid lowering of plasma osmolarity. As we mentioned before, that during hemodialysis, there is a reduction in plasma urea due to urea diffusion to the dialysate, which will cause a decrease in urea serum level, and then the intravascular space osmolarity will be hypotonic in relation to the body cells, including the brain. So in this situation, the intracellular osmolarity of the brain is higher than the intravascular space osmolarity, which will cause shifting of water by osmosis from the intravascular space to the intracellular space of the brain, causing brain edema, increased intracranial pressure, and central nervous system manifestations. The second explanation of disequilibrium syndrome is the change in cerebrospinal fluid pH, which is called paradoxical CSF acidosis. In this case, what is happening? If we are dialyzing the patient aggressively and there is a high and rapid bicarbonate diffusion from the dialysate to the patient's blood during hemodialysis, in the blood, the bicarbonate will combine with hydrogen and form carbonic acid, which will be divided into carbon dioxide and water. And at the same time, there are some bicarbonate that may keep as bicarbonate in the intravascular space. Carbon dioxide can diffuse into the brain, as it can pass the blood-brain barrier, as it is lipid soluble, but the bicarbonate itself cannot. Carbon dioxide, when it enters the brain cell water, it will combine with water, and the equation will be reversed, and the carbon dioxide will be converted into hydrogen. This hydrogen will increase the acidity of the intracellular space in the brain, and there is no bicarbonate that can diffuse to buffer this hydrogen. Because one molecule of hydrogen is more powerful than one molecule bicarbonate. What will happen to buffer the hydrogen in the intracellular space is that inside the brain cells, as in all intracellular spaces, sodium may be bound to protein. Protein will leave sodium to bind hydrogen to buffer it, to decrease the intracellular acidity. Then now sodium is free. Free sodium will increase the intracellular osmolarity of the brain, and this will osmose water into brain cells. This is called the paradoxical CSF acidosis, because as we mentioned, there is acidosis in the intracellular space of the brain, and it is called the paradoxical because while we are doing hemodialysis, we know that hemodialysis is correcting acidosis. While we are doing hemodialysis, there is intracellular acidity, and this is the paradoxical effect. This is the paradoxical effect. Okay. The third point is the intracellular osmoles of the brain. In these cases, or in this theory, when there is urea diffusion, as we mentioned before, there is decrease in the serum urea level and hypotonicity of the intravascular space. The brain cells accumulates what is called iatrogenic osmoles. These osmoles were retained by the brain cells in patients with uremia. Before hemodialysis, before starting hemodialysis in this patient has a high level of urea in the blood, which will increase the osmolarity of the blood, and this may cause shift of water from the brain to the blood. So the brain, as a compensatory mechanism to prevent shifting of water from the intracellular space to the blood, the brain cells produce a compensatory mechanism by increasing the level of these osmoles as glutamine, glutamate, myoinositol in the brain, which will increase the intracellular osmolarity to match the intravascular space osmolarity. And this will prevent the water movement from the brain to the intravascular space. So when we start dialysis and we cause high urea diffusion, this will suddenly decrease the intravascular space urea and osmolarity in relation to the intracellular osmolarity that is produced by these osmoles. And this will cause shift of water into the brain cells due to the high osmolarity in this time, at this time of the intracellular brain cells. At the same time, these osmoles are acidic. They will produce free hydrogen, and again this free hydrogen will be buffered by protein, which will leave sodium in free state, which will cause osmosis of water into brain. That's why, and it is important to show that aggressive dialysis will cause brain edema. See, the disequilibrium syndrome, mainly the main idea depends on the rapid decrease in the intravascular osmolarity due to urea diffusion, which lead to that the intravascular osmolarity will be lower than the intracellular brain osmolarity and water shift from here to here. This occurs in this theory of the iatrogenic osmoles, and also it was the same in the first theory we mentioned. Also, the other mechanism, the second mechanism that we mentioned, the paradoxical CSF acidosis, it was due to rapid diffusion of bicarbonate into the intravascular space. So, to avoid disequilibrium syndrome, we have to avoid rapid shift of urea, and we have to avoid rapid diffusion of bicarbonate. And this we will mention in the prevention later. Regarding the diagnosis of disequilibrium, actually disequilibrium syndrome lacks a definitive diagnosis. There is no diagnostic test or imaging that you can use to diagnose disequilibrium, and it is usually depends on clinical presentation. The use of imaging in these cases may be not that accurate. The next point, what is the management of disequilibrium syndrome? This depends on the severity of disequilibrium syndrome. In mild disequilibrium, you can give only symptomatic treatment for nausea, vomiting, headache. You can decrease the blood and dialysate flow rate, especially the blood flow rate, because usually the dialysate is about 500, and this is enough. You can also reduce the ultrafiltration rate. All what we are doing now is that we are trying to reduce the efficiency of dialysis. We are trying to reduce the diffusion of urea from the blood to the dialysate, and we are trying to reduce the diffusion of bicarbonate from the dialysate to the blood. The next, you can give hypertonic solution. The most commonly used is hypertonic glucose or maybe sodium chloride to equilibrate the osmolarity between the intracellular brain cells and the blood. And it is better to terminate the dialysis early, especially in acutely uremic patients. In severe cases with convulsions and coma, for sure dialysis should be stopped. Start to make first aid measures for convulsions management, and this we will talk about in the next slides when we will talk about seizures. You can give intravenous mannitol, hypertonic saline or glucose to increase the osmolality of the intravascular space, but actually mannitol is not recommended, or it is not a favored solution in patients on hemodialysis. If seizures and coma are due to disequilibrium, this should be resolved within 24 hours. But if the seizures continued more than 24 hours, you have to exclude other causes of seizures rather than disequilibrium syndrome as early as possible. And what are the other causes of seizures in hemodialysis patients? We will mention that in the coming slides. The most important strategy regarding disequilibrium syndrome is to prevent disequilibrium syndrome. Let's talk about how to prevent disequilibrium syndrome in patients who are acutely dialyzed and who are presented with acute uremia. We mentioned before that disequilibrium syndrome is common in acute patients who are aggressively dialyzed, because aggressive dialysis will cause rapid diffusion of urea with rapid decrease in the intravascular osmolarity, and also aggressive dialysis will cause rapid diffusion of bicarbonate. So you have to avoid aggressive dialysis session. For example, make the dialysis session to be of short time, for example 1.5 to 2 hours. Use small sized dialyzer, low dialysate flow rate, low blood flow rate, for example 200 ml per hour. Try to make the first session or first two sessions to be of low efficiency. And target the urea reduction ratio to be between 30 to 40%. When we discussed in the lecture of dialysis efficiency that the urea reduction ratio should be more than 60%. But actually, in these cases, as we mentioned, we want the dialysis session to be inefficient. So it's better to make the reduction ratio between 30 and 40%. If the patient is severely acidotic, again, don't correct the acidosis severely. Initiate dialysis with reduced dialysate bicarbonate to avoid rapid diffusion of the bicarbonate in the blood, which may cause paradoxical CSF acidosis. Avoid using low dialysate sodium, which may cause rapid diffusion of sodium from the blood into the dialysate, causing a hypotonic intravascular osmolarity. It's better to use dialysate sodium about 2 to 3 millimole per liter, less than the plasma sodium level. That's why it is important in patients who are acutely dialyzed to order some investigations before the dialysis. Routinely, we order viral markers to know the virology of the patient. And routinely, we are ordering coagulation profile, PT, PTT-INR, if the patient will have a central venous catheter. And you have also to order hemoglobin level to see if the patient is anemic and we need blood transfusion in hemodialysis. And also it's better to order serum sodium to know the plasma sodium level of the patient, to adjust your dialysate sodium to avoid disequilibrium syndrome. If the patient is already hypernatremic, So the patient now is uremic and hypernatremic. Dialysis will correct both uremia and hypernatremia. And this is very dangerous because correction of both uremia and hypernatremia will cause rapid decline in the tonicity of the intravascular space and will cause severe disequilibrium syndrome. So it is not preferred to correct both of them simultaneously by hemodialysis. One opinion is to correct uremia first by hemodialysis by maintaining the dialysate sodium level near to the plasma serum level of the patient to avoid the correction of hypernatremia, and then you can correct hypernatremia later by using 5% dextrose after the dialysis session if the patient is not hypervolemic. These are the lines to prevent disequilibrium in acute dialysis for patients with acute anemia. In case of chronic dialysis, to avoid disequilibrium, it is suggested to use sodium dialysate of 140 millimole per liter, but actually the disadvantage of this that it may induce thirst and intradialytic weight gain. Also, there is a suggestion to prevent disequilibrium syndrome in patients with chronic dialysis to use sodium modeling. We discussed sodium modeling in details in the lecture of intradialytic hypotension, and we mentioned that it has a lot of drawbacks as again thirst, increased water intake, increased intradialytic weight gain. So both of them are not preferred. Finally, we will talk about seizures, convulsions. What are the common causes of seizures during hemodialysis? Let's enumerate the causes, and later on let's discuss the approach, how to find the cause. First cause of convulsions during hemodialysis may be disequilibrium syndrome. Severe hypotension can cause convulsions. Hypertensive encephalopathy, hypoglycemia, hypocalcemia, hyper or hyponatremia can cause convulsions. Intracranial hemorrhage, air embolism, aluminum encephalopathy, and finally, if the patient is taking drugs that lower the seizure threshold. All these causes must be excluded when the patient caught convulsions. What is the approach to exclude these causes? We will mention now while we are talking about management. What is the management of patients with seizures during a hemodialysis session? Immediate management, you have to terminate the dialysis session, secure the vascular access of the patient to prevent its damage, also secure the patient himself, ensure that the patient is not in danger of injury and in a secure setting, administer fluids and oxygen. Most of the convulsions resolve spontaneously within 5 minutes. But if the patient continues to convulse, you have to achieve airway protection and stabilize the patient. You have to administer intravenous benzodiazepines as this is the treatment of a choice to terminate convulsions in these patients, and finally refer the patient for neurological consultation. After the seizure has been remitted, you have to find the cause. First of all, one of the causes of convulsions is disequilibrium syndrome. Disequilibrium syndrome actually is a diagnosis of exclusion. So what to do in patient with convulsion on hemodialysis? First, assess vital signs, because we mentioned that both hypotension and hypertension can cause seizures. So assess the blood pressure of the patient. And then order blood sample for the serum level of glucose, calcium, sodium, magnesium, and other electrolytes to exclude hypoglycemia, hypocalcemia, hypernatremia, and hyponatremia to be the cause of these convulsions. Then you have to order brain imaging to exclude intracranial hemorrhage. If the cause is air embolism, as we mentioned that air embolism may be cause of convulsions, it will be clear as there will be foam in the bloodlines, as we mentioned. Regarding aluminum encephalopathy, I think this is very rare in our patients, but if it is suspected, the accurate diagnosis is bone biopsy and it is not performed. Selected cases, this is maybe followed by deferoxamine stimulated serum aluminum level, but actually I think this is not more common in our patients. So you have to assess vital signs, order blood tests for glucose, calcium, sodium, and maybe magnesium, brain imaging, revise the patient's drugs, because the patient may be taking a drug that lowers the seizures threshold. And finally, if all of these are normal, so the diagnosis may be disequilibrium syndrome. Also, you can exclude recent star fruit ingestion if this is common in your area, but actually it is not common here in Egypt. So this is the stepwise approach in cases with convergence. I hope that you liked my lecture. I will see you in the next lecture where we will continue discussing the intradialytic complications that occurs during hemodialysis. Thank you.